Dr. Scott is the Clinical Research Medical Director at Bridge HIV in the San Francisco Department of Public Health and is an Assistant Clinical Professor of Medicine at the University of California, San Francisco. He received his medical degree from Yale School of Medicine and completed his internal medicine residency, chief residency, infectious disease fellowship, and postdoctoral research training at the Traineeship for AIDS Prevention Studies at UCSF. He has a particular interest in the epidemiology of HIV-related racial ethnic disparities among men who have sex with men and interventions to reduce these disparities. Dr. Scott currently has an NIMH K23 award to develop and test a mobile app-based combination HIV intervention in time of home HIV self-testing, STI self-collection, and the subject of today's discussion, pre-exposure prophylaxis uptake among young Black and Latino men who have sex with men in the San Francisco Bay Area. So he will be leading the presentation, and then subsequently there will be a panel discussion. Well, as part of it, there will be a panel discussion over different cases. So without further ado, Dr. Scott.
Thank you for that introduction. And as Britt mentioned, I am from San Francisco, and I was at Ward 86 on December 4th. And so I just wanted to appreciate and acknowledge the acknowledgement for the loss of Alberto, who is really the heart of our clinic. And as we've gone through the healing process for what happened, it's been clear that there's been a lot of things happening both at our site, but also across clinics that are sort of working to support the most vulnerable of our patients living with HIV. So I just, in remembering Alberto, we also have been advocating for our staff to have safer work environments, and just to remember that as we advocate for the things that our patients need, that we also need to advocate for what we need as providers, and safety is one of those things. So I just encourage you to advocate as hard for your own safety as you do for the care and consideration you give to our most vulnerable patients. I'd like to just transition into our panel discussion. So I have the honor of providing some cases to this esteemed panel to try to stump them on pre- and post-exposure prophylaxis. So before I get started, I'd like to just have the panelists introduce themselves. And this first panelist, Michael Sag, go ahead and get started.
I told you I'm like keep returning, but hello. Good to see you all again.
Hi, Carolyn Chu, also at UCSF and with the AEDC National Clinician Consultation Center as well.
I'm Trip Gulick from Weill Cornell in New York City.
I'm Melanie Thompson from Hotlanta, Georgia, in private practice.
Hi, I'm Sandy Springer. I'm at the Yale School of Medicine, Infectious Disease.
Roger Bedimou from the VA North Texas and UT Southwestern in Dallas.
Okay, great. Thank you, panelists. So I have no relevant, oh, that is very close, no relevant financial relationships. And so these are the learning objectives for today. We're going to talk about HIV testing, initiation of PrEP as well as in follow-up, talk quite a bit about long-acting lenacapavir for PrEP, and then describe the most recent NPEP guidelines that were released this year. So this is case number one. So this is a 30-year-old woman who was interested in starting PrEP after one of her friends was diagnosed with HIV. She has no significant medical history, was diagnosed with vaginal chlamydia approximately 5 years ago, but has not had a recent STI. Although I would offer her doxy-PEP as well, but that's not the point of this talk. She's open to oral PrEP or injectable PrEP, but is leaning towards an oral option after doing some online research and concerned about pain and other injection site reactions with injectable PrEP. So we have an ARS question first, which is what PrEP option or options would you offer her? Injectable PrEP with CAB, LA, or LEN, daily oral PrEP with TDF-FTC or TAF-FTC, daily oral PrEP with TDF-FTC only, or on-demand PrEP with TDF-FTC or any of the above. So give it a couple more seconds to get some great responses. So I think we're about halfway through the number of attendees, so I'm going to go ahead and move forward. So, okay. So the audience, 62% said they do oral prep with TDF-FTC only. So I wanted to turn to the panelists and see if any others have thoughts about the selection of oral prep for this this woman who's interested in in an oral prep option. Does everyone think this is the only option for her?
Well, I think she doesn't want injectable PrEP right now. That's a problem because, you know, they would be good options for her, but she doesn't want that, at least right now. And the problem with TAF-FTC is that initially the big Discover study, which randomized people to PrEP or placebo, didn't include women. So the TAF-FTC arms didn't include women. So the approval didn't include women, and that was a bit of a problem. And then when we saw it included in the PURPOSE trial, it actually didn't redeem itself very well with that trial, and was overwhelmed by the benefit of lenacapavir. So right now, I think TDF-FTC is the best option for her. I wouldn't say that TAF-FTC would be out of the question. I think it is, we suffer from a lack of good data, but there are not a lot of data suggesting that it should not work in women. So,
Yeah, I see. Roy, did you want to add to that?
Call me Trip, Hyman.
Trip, okay.
Everybody does, right? So what's interesting about the PURPOSE study, of course, is that we know that adherence was the problem with the oral arms, and the TAF-FTC arm did about as well or as poorly as the TDF-FTC arm, really substantiating that it does have adequate activity if people are going to take it. IAS-USA actually incorporated TAF-FTC into their guidelines for women, although you're right, the FDA approval does not include women for that option. I wanted to go back a step and say, do we really want to not even talk about injectable PrEP in this woman? She's heard about injection site reactions, and that's important, but maybe we provide a little more education as to what exactly she might expect. And some people might be willing to try it, if not now, then for the future. So probably we should have a conversation about it, even if we ultimately don't go that direction.
Yeah, so did you have a comment, Sandra? Or
Oh, I'm glad Trip brought that up because that's the philosophy I use. It's like in education, potentially about the lenacapavir and cabotegravir, but it's a patient choice kind of decision-making and shared decision-making process that we use. And in fact, the population that we're seeing who wants the lenacapavir the most when they're offered it are women. And so I think it's something they may not have heard about and what they're willing to do. But yeah.
Okay. So Carolyn and then Roger.
Oh, Carolyn?
Sure,
Oh,
yeah,
go ahead.
just quickly. Yeah, I mean, I think it's good for us all to be future looking, and I was actually going to also try to bring on-demand PrEP back onto the table as well, because again, I think PrEP use, I think, is really fluid, and so while we might be in a space that we've got the most experience with daily FTDF for this scenario, I do think there's going to come a time soon, hopefully, that we can sort of have more support to bring on-demand PrEP into conversations with women as well.
Great.
Yeah, I wanted to agree with everyone else that what's very important in PrEP is persistence. People usually look at people who start PrEP, but people who stay on it for a long time, few. So whatever somebody is saying that they're concerned about, they're probably not going to persist, and you don't want it. But regarding TDF versus TAF, I agree with the data that called, for more information on TAF in women. But also want to look at Jean Marazzo's data in Africa that I think has done some to give us more comfort in that. So.
Yeah, that you don't need to have as high adherence in terms of 7 days a week, and that you can get high protection even with lower levels of adherence.
Correct.
Okay, Mike.
Yeah, so everybody else spoke, so I think I need to.
You
So
want the
to
last
me-
word, Mike? Is that
yeah,
right? Okay.
To me, the concept of shared decision-making is the same as diet and exercise with weight control. So you always want to have shared decision-making.
Yeah.
We should say one more thing. If this was a board's question, then you got the right answer.
Yeah.
There's one answer, no subtlety. That's the data-driven answer.
Yeah. I wanted to maybe go forward.
It should go.
I know, but there's a backup.
There it goes.
Oh, okay. So these are the recommendations that are in the IAS-USA guideline in line with the CDC guidelines that most recently added TAF-FTC based on the data from Purpose 2 in Southern Africa that compare lenacapavir to background rates of HIV, as well as to TDF-FTC and TAF-FTC to address the issue that was raised that we don't have data among individuals having receptive vaginal sex. So the FDA label for TAF-FTC excludes the use of it for prevention for HIV among people having receptive vaginal sex. And then to the point around shared decision-making, I think we really are starting to center this around our PrEP discussions with our patients because we now have a lot of options. And as Roger mentioned, that we see really terrible persistence. To be honest, the most people who start PrEP are only on it for about 6 months. And I think we talk about seasons of risk and people's decision-making, but also PrEP is also a hassle for a lot of people to get, and that hassle includes some of the systems as well as insurance. So I think thinking about shared decision-making to help people start and stay on PrEP. These are the data that were presented from Purpose 2, and these data were submitted to the FDA for review and approval. These are not the same as randomized controlled trial data. This was a matched case control study that looked at individuals who were randomized to TAF-FTC and took it versus those who didn't take it, and in comparing it in this adherence cohort to those in the Discover trial, which did lead to the expansion of TAF-FTC for HIV prevention. And as you can see, we've seen this with other oral regimens for PrEP in women in Southern Africa. And when we looked at matched controls who had high adherence versus those who didn't have high adherence, there was high levels of prevention efficacy that you could estimate from that. So I think like some of our other use of off-label indications for medications, IAS-USA has included TAF-FTC in the indication for HIV PrEP. We have included in our local guidelines in San Francisco and are now offering TAF-FTC to women who have receptive vaginal sex based on these data, and we use shared decision-making, explain these data to them, and have a decision about whether or not to initiate it. So this is one of the key takeaways. So I try to have these slides. So really, we have an expanding choice of PrEP options. We should be making these decisions with our patients, not for our patients, because we want to both support uptake as well as continuation. And that the Purpose 2 data are quite useful in providing us clinical data for the use of this for people having receptive vaginal sex, which is an off FDA label use. Okay, case 2. So this is a 25-year-old woman who is interested in switching from TAF-FTC to CAB-LA and contacts you prior to her scheduled PrEP follow-up visit to let you know that she wants to make this change. She's been on PrEP for several years, but has had more trouble with adherence after starting a new job with variable hours. Her partner is living with HIV and recently switched to injectable cabopivirine, which is what prompted her interest in injectable PrEP. Her PrEP follow-up visit next week, and she wants to come in for labs in advance of that visit. So what HIV testing would you offer in advance of this visit? So would you do a lab-based antibody antigen test and viral load, a lab-based antibody antigen test only, a lab-based antibody antigen test and a rapid test, or just do everything that you can? All right, so we'll let the audience respond and the panel consider. Oh, it's not coming up? I don't know if yeah, it didn't look like any of those. So we could do it old school and have people raise their hand. How about that? Okay.
0, 0,
0, 0, 0. So how many people would do A? Great. How many people would do B? Oh, sorry. We're making this challenging for you, so. Oh, there,
no,
oh, there it was, sorry.
I feel like I had a magic wand.
So let's wait a moment. Fatima's on it. So does anyone recognize the music that's playing in the background? Has anyone been to Ibiza?
Visa.
It's, do you know who this is? Yeah, it's Black Coffee. He's one of the South African DJ who's started a lot of the notoriety for Ibiza being a destination for music. And this is with Alicia Keys, who's did a duet, collaboration with him recently. So, all right, that's all. I'm trying to keep up with Mike, but I don't have as many references to Broadway shows. But I'm working on it, Mike.
Trip.
You and Trip.
I guess we can just have the discussion.
Okay, I see Fatima back there working very hard.
Should we discuss it?
Hyman, you want to, should we just?
Yeah, why don't you all comment on the HIV testing in the setting of this switch? So this is a PrEP case, someone switching from oral to injectable PrEP. How do you think about HIV testing? Do you want to go, Trip?
Yeah, sure. There's two key elements here, I think, that are guiding us. One is that she is intermittently adherent with her PrEP, so that raises the concern that she could have acquired HIV. And the second is that her partner has HIV, and we don't know a lot of the details about her partner. So those two things make me think, okay, we need to do antibody testing, but we probably need to add an HIV RNA as well. I don't see the benefit of doing a rapid test. She's getting these tests a week ahead of her visit, so we're gonna have the conventional lab-based antibody testing. So I think that was choice A, if I remember.
Oh, yeah, it's back up.
Ah,
Okay.
it's
Yeah,
back.
so it's choice A.
So yeah, I would vote for A here.
Okay. Does anyone go for any other choice? We want to try to influence the audience since they're now also voting.
Whoever is wearing Levi jeans should go first.
Explain yourself,
Concern being,
mister.
Oh,
here
Levi
being that,
syndrome.
yeah, that the person was on, the partner is on antiretroviral therapy with cabotegravir or ribavirin that's possibly transmitting a virus based on that. That if you acquired HIV, but that person was not on PrEP with ribavirin, so that's not a consideration here.
Yeah. So for context, the partner has been virally suppressed for multiple years, so has not had any breakthrough or viremia.
Oh, okay. Sorry, I wasn't on the microphone. Yeah. So the consideration being that if that person switches on cabotegravir, and if they were to acquire HIV, since they're in a relationship with somebody with HIV, we need to be concerned about the testing missing an early infection.
An early infection, yes. Yeah, great.
Thanks for that clarification. I was actually thinking of two possible scenarios where actually D could be considered. I think one is just, I didn't want to make the assumption that everyone's turnaround time for an antigen antibody was actually going to be within a day or two. And I think if you don't have access to a lab that's going to give you results quickly, and if you have capacity to offer a rapid test, for example, if you're working in a mobile unit, I do think potentially there might be a role if, let's say, the partner was viremic, because I think a positive result on that rapid is actually going to maybe sort of help, like, you're going to go down one different pathway than if that wasn't the case.
Great. Any other thoughts on this case?
There's one other thing to say. If we knew that she was fully adherent and she was just switching from one PrEP modality to the other, then I think it would be okay to do B, just the lab-based test only. You don't need to do the viral load. And I think the guidelines also have, IAS-USA guidelines support that strategy.
Perfect. So that was really a great lead into, I think, what we wanted to send the message. I think there's been a lot of movement towards inclusion of HIV viral load testing, in particular for CAB-LA and concern about the Levi with these sort of smoldering HIV infections, and that the new guidelines have really started to move away from this. CDC guidelines are being worked on, but the IAS-USA guidelines really sort of suggesting that HIV viral load testing is not necessary at it's for the use of CAB-LA, particularly when you're initiating, this is when it's useful. So you want to identify someone who's not been on PrEP, who might have unrecognized HIV infection, or if they have acute HIV. And then at follow-up, the guidelines actually do suggest inclusion of a rapid HIV antibody test if it's available. Now, not every clinic can do rapid testing because it requires CLIA waivers, and if you're in a hospital setting, it means extension of that from the laboratory to your clinic, and we've actually run into a lot of those problems at our clinic as well. So it's not always feasible. And then routine RNA testing is not only expensive, but is also not available everywhere and has a very long turnaround time sometimes as well. And so, we have been sort of moving away from the HIV viral load testing, and the data suggests that actually you're more likely to have a false positive if you do a viral load than you are going to actually identify an unrecognized infection. So a positive viral load test in the setting of CAB-LA from this study from HPT and 083 suggests that that's more likely to be a false positive than a true positive. And so we really have moved away from HIV viral load testing with CAB-LA because we were seeing and chasing all these false positives that were causing a lot of honestly breaks in people's PrEP use, as well as lots of concerns both the providers and the patients about acquiring HIV while they were on an extremely highly active. I wanted to address also the question around adherence, and this comes into the art of medicine around how you manage if someone reports poor adherence. Was a viral load test. We saw in the HPT and 083, a lot of on-time injections, but there is a lot of variability in adherence. I think what we try to do, and I think to the questions that came up during syphilis is like really the history. Someone doesn't have acute HIV symptoms, has been taking it at levels which we think now don't have to be perfect adherence to have high protection. There's really a low likelihood that that person has acquired HIV, even in the setting of suboptimal adherence. So I think that those are lots of considerations. We're still learning a lot. We're still collecting a lot of data to try to provide the evidence to support some of these changes, which hopefully will be.
Hyman,
yes.
can we just?
Oh, yeah. You go ahead.
No, you. It's all about you, Melanie. You do it.
So we're probably going to say the same thing.
know.
I don't know. Well, I just want to be sure we distinguish between doing HIV RNA tests for someone who is currently taking CAB-LA, so they come in for their visits, and that's where the HIV RNA is maybe false positive. But I think there should be a fairly high bar for being sure someone doesn't have HIV when you put them on PrEP treatment. And particularly, we have the history that, taking pills isn't working out very well for her. So I would agree that the adherence thing with her makes me a little nervous. So that's different than following somebody on CAB-LA with an HIV RNA. Just to be clear.
I was going to say the same thing. These data are routine follow-up of someone who's getting their CAB-LA injections for PrEP. In the case you described, we got a history of non-adherence. So I just think differently about that patient.
Yeah, and I think that's an excellent distinction. And I think what I want to highlight was this transition. As we have all these long-acting agents, there are going to be people who are transitioning from oral PrEP into injectable PrEP, and I think our approach to them can be different than if someone is like newly initiating CAB-LA, has never been on PrEP. Even in the setting of suboptimal adherence, taking a history, getting a sense of what they have, that we can be a little less, I think, people seem to be nervous about making this switch and treating it like an initiation de novo for PrEP. But if someone is on oral PrEP and has adherence that we think is associated with prevention, it's not wrong to do a viral load. But I think that is a high likelihood that you're going to have a false positive if someone has had, has been taking oral PrEP. So it's what wanted these cases, so there's controversy, and there's a different approach to this. So did you have something?
Oh, no, I was just going to say that's how we practice and have not seen any HIV in that setting and able to give cabotegravir immediately on the mobile pharmacy clinic.
Yeah, and that's the other point is like this person was coming in before, so you had an opportunity, but do you have an opportunity to like just switch someone same day without having a delay?
Oh, I don't know if you might bring this up later, but I was just going to say, I mean, this is the art of medicine, and we know that there are many different types of nucleic acid tests, so I think some of it also might, some of the nuance may also be, you know, if you ordered a quantitative, right? Viral load of 10,000 is going to feel and mean something very different than if it was 100. And ultimately, I think when we get calls about this on the hotline, you know, most people will just repeat it right away. And so I think if you're able to get that second viral load back quickly, again, that's more information you can use in your decision making. We certainly don't want to see people have breaks in their PrEP use.
Perfect, exactly. Okay, all right, so I'm just gonna move through these as we get to case 3. Okay, so now we're into injectable PrEP. So 36-year-old man who's been on and off PrEP for the past 10 years. He has previously used TDF-FTC, both daily and 2-on-1, and he recently opened his relationship and is interested in injectable PrEP. He struggled with adherence, and he self-describes his HIV risk increasing. He has a history of hypertension and diet-controlled diabetes type 2. He reports occasional use of ketamine, GHB, and Molly over the last 12 months, mostly at parties. And he has traveled often but has never missed a scheduled appointment. So which non-daily PrEP options would you offer him? CAB-LA, lenacapavir, TDF-FTC, 2-on-1, or CAB-LA or len, or any of the above. All right, and I think the Slido is working now. Great, we got lots of responses. All right, so we'll go ahead and get started. So looks like half folks would offer CAB-LA and another quarter would offer any of them. And anyone on the panel have thoughts on this?
Yeah, I would have picked D as well. I think either could work. You know, I'd lean a little bit towards lenacapavir because of the 6-month dosing, and I think the data are pretty spectacular on its effectiveness. So with him traveling and not being as adherent, I think that's probably where I'd lean. But again, I'd go back to shared decision-making and see what he wants to do.
Great.
Yeah, I would agree with that. And the other thing is he's engaging in substance use. So as we'll hear about later, is also identifying and if he needs or wants, substance use treatment and other services. So how is he using his how is he using his drugs? Is that the substance use itself putting him in more situations that he might be at risk for, but also having the option to have a long-acting injectable on board, like lenacapavir or CAB-LA, that he doesn't have to worry about the HIV prevention aspect, but we still have to do other things about his substance use and potentially at risk for other STIs.
Great.
Sorry, one thing I don't know that I would need to look up, and that is drug interactions with the ecstasy or the ketamine or those other things. I'd need to know that beforehand.
Or we didn't hear what his meds were for his hypertension and his type 2 diabetes. So
Yeah.
that's another thing. You want to be careful about lenacapavir drug-drug interactions.
Great, such a good panel. So that's exactly the point of this. I'm going to get to that in a second. We have some options for evaluating these drug-drug interactions, and I'm going to show you some orange flags that came up when we looked at lenacapavir interactions with recreational drugs. But first, I just wanted to recenter on the Purpose 1 and Purpose 2 trials. This is the Purpose 1 data that I talked about briefly, where it was the first clinical trial where we saw really 100% efficacy in this very large trial. And then the Purpose 2 data, which showed also a very high efficacy for prevention with injectable lenacapavir twice a year.
Hyman, are you going to mention, both of those studies have seen now one or two seroconversions after those data? were published? It's in the package insert.
Yeah, so it's not, there have been cases, and there have been more cases, and there have been more characterization of those cases, so for sure. So it's not, so we don't tell people it's 100% efficacious in preventing HIV, but this was the clinical trial data that was presented. So we do try to highlight that this is highly effective. And they do have a better description in the package inserts about these cases. I do have a couple of the cases from the Purpose 2 trial, which sort of describe a little bit more about what the resistance patterns that developed. There's been a lot of questions around lenacapavir rollout. I think that we have some really good resources that have been developed, and just a reminder for the dosing schedule that it's 2-2-2. So on day one, it's 2 tablets of oral len that are 300 milligrams each, and there's 2 injections of 1.5 milliliters in the on-label spots, which are abdominal and thigh, and the off-label spots, which are buttocks and back of the arm. And then the next day, the patient is to take another 2 tablets of 300 milligrams. So it's important, and I think a lot of our implementation has been about how do we support our patients in taking those 2 doses, whether they come back and do it in clinic, or they have a telephone visit to continue that. And then every 6 months, coming in for the additional 2 injections. We've had some experience with injection site reactions we'll talk about as well, and then just continuing on the dosing schedule. The injections do require these very special needles, so I think for those who are administering lenacapavir, they look thicker than they are. They're 22 gauge, and it's because they're thin-walled needles. So if you drop one of those needles, you can't just grab a 22 gauge from your site supply. There are special needles that are used to administer this. So you can ask the manufacturer, the pharmaceutical company, to give you additional needles. That's actually what we've done at our clinic, just to make sure that we don't not give an injection because of something like that happens. There are non-abdominal sites that are available, as I mentioned, on the back of the arm and the back of the buttocks. Those do seem to be, in the clinical trials, more tolerable than the abdominal sites. And so I think we've been offering those more than the abdominal sites for many people. And it's being submitted, I think, to the FDA for a label extension very soon, so we should hopefully have that in the FDA label. And that sometimes a more shallow injection can lead to really severe injection site reactions, and there have been some sort of necrotic nodules that have occurred in the setting of these injections being given too shallow, and so essentially intradermal, so they can be quite, and require debridement and things like that. So they can be quite complicated if they do occur. There are resources, and there's nurse training programs as well to support the administration. But I think that, for people who really don't want to take and come into the clinic very frequently, this has been a really great option to offer people. And as one of my colleagues, Monica Gandhi, says, this is a feature, not a bug of lenacapavir, that those nodules are the most common injection site reactions. We have found that icing for 10 minutes really is transformative in the amount of pain that people experience with these injections. So we do that. We don't use cold packs. We actually use ice packs from our -20 freezer. And that they average about the size of a grape, but they do last a long time. So I tell people that, this is 10 to 12 months that these nodules will last. So I'm really trying to give people anticipatory guidance. As we talked about, we want people to choose a regimen that's going to work for them and then stick with that regimen. And that the nodules are probably the most common thing that we spend our time talking to them about. And so in terms of missed doses of len, we ran into a lot of this with cabotegravir, how do you manage missed doses? There are oral lenacapavir that you can get, and it's actually not that difficult to order that. And then it's taken once a week, and that can be taken for up to 6 months. And then we restart the initiation dosing if we're able to continue them on the oral len. So for this patient who might be traveling, this might be something that you give them the oral len, so that they can take that if they happen to be traveling when they need to have a dose. This is the Liverpool interaction that came up. So this patient, as we mentioned, is using GHB. And so there is this concern potentially for lenacapavir to have an interaction with GHB. And as they described, GHB has a very narrow therapeutic window, even though it's like recreational drug. But it is, something that we look at and consider. There were some data presented at ID Week that suggests that the use of recreational drugs did not result in more adverse events in that trial. So I think that we're getting more comfortable that, the amount of recreational drug use that was occurring in those trials didn't show up as adverse events among our study participants. But it is a concern, and there's a lot of drug-drug interactions. There was a concern also around methamphetamines and fentanyl. Again, we didn't see those in the clinical trials, and despite some of the interactions that will pop up on the Liverpool. There's a lot of interactions with lenacapavir and other drugs, and it's like really kind of complicated the way that this interaction occurs. And unlike lenacapavir for treatment, there are no contraindicated drugs in the same way that they have a list in the lenacapavir for treatment FDA label. So I think that's partly intentional to allow very few exclusions for lenacapavir. And these are all listed in the package insert, and this is sort of the strong CYP3A inhibitor inducers and the moderate CYP3A inducers, and how to manage lenacapavir in the setting of use of one of those drugs. So when you have a substrate that's PGP or UGT1A1 or a CYP3A, you do supplemental len dosing. And then if it's a moderate inhibitor and a PGP inhibitor, you may increase the concentration of those drugs. So it's pretty complicated. We work closely with our pharmacists. And then what's not always clear is how you manage this if someone's already on one of those drugs and not initiating one of those drugs after they initiate len. So, these have a very long tail. So really encourage you to use your pharmacy resources as well for this. It is contraindicated in some medications, and we use caution in some of the statins, in particular simvastatin, lovastatin, as well as opiates and benzodiazepine. Yeah, I have some.
I would just say one of the tricky things here is that it's a long-acting drug, and they get it once and forget about it for 6 months. And so it's great when they come to your office and you're prescribing the rest of the drugs, but what about when they go to the cardiologist? And if they don't have all the information, the patient doesn't really think about it, then I think there is a potential. So I spend a good bit of time, talking with patients about educating their doctors. And I also tell them, if somebody else gives you a medicine, just call us. Just call us and check it out. Probably going to be fine, but, you wouldn't want them to get amiodarone, right? Mm-hmm. That could be a really bad outcome. So, I think these are things that it just takes a little more time. It's a different kind of drug. We're not used to dealing with these kind of agents. So,
yeah. Good point. Do you have a comment?
Oh, yeah. I was just going to flag one thing, though, about sort of the administration technique, because if you notice on the package insert, it says sort of ideally 90, but no lower than 45. We've actually gotten some calls about sort of leakage of the fluid, and I think we really don't know what to do in those circumstances, because you're like, how much is in there, how much is not? Do I give another,
Yeah.
There's not a lot of data. So.
Yeah, and there's no guidance on, is it covering the Band-Aid or the gauze, or, do you need to change the gauze and how much? I think one of the things that we found is that when you administer, we do try to do 90 degrees, and we do try to hub the needle. We pinch the skin, hub the needle, and then we hold it for 10 to 15 seconds so that anything in the needle goes into the subcutaneous space, and that seems to help with the leakage. But it is being reported. It's not really clear exactly what to do in those cases.
Yeah, Hyman, I just wanted to reiterate that it's great to go through that caution about people who will be missing doses, but the same thing should also be said with CAB, because it also has a long half-life. Even if we know what's the process, it's always important to have close at hand what to do when they miss for 1 week, for 2 weeks, for 3 weeks. We know that, that's really, really important if we want to manage this.
Yeah, that's a great point. And I think as we get more and more long-acting agents, we're going to need to come up with different strategies for this. What's been nice for LEN and for CAB actually is that we've been able to get the oral doses relatively easily. Our local guidance actually been to use TDF-FTC, but then it became more problematic to get that from the insurance if they're already on the long-acting. So some of those operational things I think we found to be helpful. So just a comment on resistance, that resistance did occur. This was a recent study that was published in JID, that resistance identified in Purpose 1 and actually none of the participants, and then 2 of the participants in Purpose 2, and they both were associated with the LEN resistance mutation N74D, and that, this is sort of thing talking about viral load testing at baseline. These 8 participants across studies had unrecognized infection at baseline, and then that's really where the highest risk of developing this mutation as well. 50% of those developed the N74D in that setting. And these are some of the cases. So this is from Purpose 2, just to highlight that these seem to occur at the even at levels thought to be associated with protection, and that there did not seem to be the same level of Levi syndrome like we saw with CAB, that these individuals had high viral loads that didn't appear to be delayed diagnostics like we saw in many of the CAB breakthrough infections when there was on-time injection. So this was case participant A and this participant B. You can see in the blue where the HIV diagnosis occurred. They had viral loads that were all above 10,000. Okay, so these are some of the key takeaways. LEN has high efficacy. Injection site reactions are common and last a while. Lots of references, and then we say phone a pharmacist to really help with some of these drug-drug interactions, and that we're not using LEN now for primary alternative therapy. I think there's a possibility that this might become a more commonly used treatment option, so this is something to consider with the resistance. All right, so case 4. So to score an HIV test, so a 27-year-old man, it's on 211, comes in for a routine PrEP follow-up and reports intermittent use in the last 3 months. He denies any acute symptoms and does not report, but does report COVID-19 symptoms last month after his roommates were diagnosed, although he tested negative. So he has testing at this visit, and his rapid HIV test is negative, and his lab-based HIV antibody antigen test is positive, but the confirmatory test is negative, and then you have a reflex HIV viral load that's pending, but it's going to take a week. So what do you do? Do you continue his PrEP? Do you stop PrEP but don't start other ART until you have this result back? Do you stop PrEP and start BIC TAF FTC, or do you stop PrEP and start darunavir, cobicistat, TAF FTC? Okay. All right. So, this is great. So 40% of people would stop PrEP and start BIC TAF FTC, and about 30% would continue PrEP, and 20% would stop PrEP but wait to start any other ART, and about 7% would stop PrEP and start darunavir, cobicistat, TAF FTC. What does the panel think? Mike, what are your thoughts?
Yeah, I would lean towards what the audience said, mostly because he had an acute viral illness that otherwise was unexplained, and so that with the positive reflex test sort of leans me towards that this could be a new infection. The question really that we're debating is what to do in that small amount of period where you might treat or you might not, and it's like dancing on the head of a pin a little bit. the reason to start, and the way I'm leaning that way, is that if he's still sexually active, that you could begin to reduce the viral load if that were present. The negative genius test, that's an IgG-based test that can be negative early on, so I'm less taken with that, but thinking maybe this is an antigen that's positive here. So I'd lean towards treating because it's earlier infection. If it is, then we'll know in a few more days whether that was an overreaction or whether we're on the right track. I'm assuming that plasma would have been stored from that first blood draw to check for resistance, but that's kind of where I would go.
Okay. Would anyone continue PrEP?
I don't know that I would continue it, but I think, I mean, it is about shared decision-making.
Yeah.
I do think it comes down to sort of maybe seeing if the patient's able to share a little bit more history about their exposures or recent partners. You know, I think many of us, I'm assuming, are comfortable starting treatment, and yet this person was on episode or event-driven. And so I feel less pressure in terms of stopping and starting, and I would maybe just want to let the patient know there's multiple options. None of them are right. If you really do not feel ready to start BIC/TAF, even if it's just 7 days, I'd want to talk through, you know, what I think they should know is, you know, if they were to do the other options.
And is anyone in the panel? Do you have?
Well, I always worry about stopping PrEP because he's on PrEP for a reason. And, you know, the worst outcome would be to have this false positive test and we stop PrEP and then he really gets HIV. So that makes me a little nervous.
And that's why C may be the safest choice here, because you're really covering that base as well as could this be acute infection. And you do have a test pending, so there is a exit ahead just in case we guessed wrong about that here.
Yeah, the BIC/TAF FTC is super PrEP.
Super PrEP.
And PEP.
And PEP, yes, yes.
Not at all.
Let's not put PEP into
It's
the
actually a transition
to the
to
back.
PEP.
What's that?
It's actually a transition to PEP.
Yeah, it's essentially a
Until we
transition
know.
to PEP. Is anyone concerned about resistance?
No, it's just TAF, right?
Even if it's there, I think, you know, there are emerging data saying that ultimately if this person has acquired HIV and does have some limited nuke resistance, BIC/TAF will likely suppress. And I think, you know, and a couple years ago, there may have been people who are more comfortable with doing the boosted darunavir, but I do think now we're starting to not be quite as cautious.
And if he did have resistance, it would be to FTC, and we know that that triple combo would still work very well in that case.
Yeah, perfect.
Although we may not, I doubt people are going to save a sample to test for resistance testing. I mean, if you can, that'd be great, but, so you may not know the answer to that.
Or you could, if you're thinking all these things at once, then you might order the HIV RNA and send off a
genotype.
resistance test on that same draw.
Yeah, that's a good idea.
Yeah, and I think that's what we generally do in these scenarios, and they won't run it if there's no viral load. Okay, great. This is a complicated scenario that I think we have been encountering, and actually we've been encountering a lot of it with the positive viral loads, to be honest. This is a slide that really there are options, and I think this is also part of shared decision-making around whether you continue PrEP and that there are pros and cons to any decision, doing additional testing, and potentially collecting a resistance test if you sort of have a higher suspicion, but you have options and you have resources as well to sort of get support on some of these. And so these are some of the resources. The National Clinician Consultation Center, and then there's a study called SeroPrep that's actually looking at whether or not to better understand HIV acquisition in the setting of use of oral injectable PrEP. So some great resources available.
Are the people at that national consult, Caroline, are they reliable?
I think they're mostly legitimate. Mostly.
They're mostly reliable.
Can we throw in another commercial? If you have a patient who acquires HIV either on CAB PrEP or soon LEN PrEP, the ACTG is collecting those patients. So if you have an ACTG near you, it'd be good to refer to them, and they can help you work through this troubling situation and provide extra testing too.
Yeah, great. great resources.
I think they might be offering co-enrollment, I believe, yeah.
Yeah, okay. All right, so we're going to have an MPEP case, and then hopefully time for questions. So 45-year-old woman reports condomless vaginal sex with a new sexual partner 2 days ago. She would like to start post-exposure prophylaxis, and her pregnancy test is positive. So what regimen would you offer her? TDF-FTC, TAF-FTC, BIC-TAF, dolutegravir, DTG, TAF-FTC, raltegravir, TAF-FTC, darunavir, cobicistat, TAF-FTC. All right.
We talked about this in our guidelines.
Great. So, looks like 70% of folks would offer BIC-TAF, FTC. Carolyn, do you want to?
No,
comment
this
on
is
that?
this is great. People have
Yeah.
read the new NPEP guidelines. Yeah, just it got upgraded,
Yeah,
basically.
great. We've been upgraded. All right. Any other comments on?
We should throw in that the perinatal guidelines also updated in the past year, and BIC is now among the preferred integrase inhibitors. So the two guidelines sort of overlap right here of choice C.
Yeah.
There's a couple of wrong answers here, I think. You can't use cobicistat in pregnancy because its levels are decreased. So F is not a good choice here. And then two drugs, A and B, that's not PEP, that's PrEP. So those probably are not the right choices either. And raltegravir twice a day, why would you do that
Why would you do
to
that?
anybody?
So the one thing I might add, and this is not guideline-driven, but you remember the concern about neural tube defect in the first 4 to 6 weeks. Folate is really the remedy for that in a way. So I would probably, as I start either dolutegravir or bictegravir based, I'd give her some folate just to kind of add additional assurance. The OB docs usually give that anyway, but that's something else you might think about doing at the time of initiation.
Yeah, and also why the guidelines changed after the impact to 010 study, that dolutegravir moved from bad drug to a drug that had some of the best outcomes in pregnancy for the baby and the mother. So, and while bictegravir did not have a lot of data in that sphere before, but now I think as of this year or last, it's okay to, this is, so I agree with the choices.
Great. Carolyn.
Yeah, maybe just, I don't know if this is the last slide, but I will sort of highlight that the exposure was 2 days ago, and so we also know that not every pharmacy has BIC-FTAF in stock. And so if you actually find that the person is having trouble or will have trouble as soon as they walk out the door, then I would say just maybe do some troubleshooting and see what they can get on board most quickly. And it might be DOLU and FTAF or DOLU and FTDC. So I think that's like real world Pearl.
Great. Yeah, so these are, as people mentioned, MPEP guidelines for sexual exposures, and they really have sort of coalesced around BIC-TAF as a preferred regimen with darunavir, ritonavir for individuals who can become pregnant as the alternative regimen. These guidelines were recently published, great resources. And then there's suggestions on laboratory testing as well, so initial HIV testing with a lab-based and rapid if available, HIV NAT if injectable PEP, injectable PrEP in the last 6 months, and then follow-up HIV testing with antibody antigen and other safety lab testing. The clinician consultation line also supports PEP, so another plug for the NCCC. And then there's actually been some data on PEP in pocket, and I'm not sure if any providers are offering this, but this is something that we're going to be offering more and more, I think, in our clinical settings, where individuals who are not interested in PrEP, for example, and have intermittent potential exposures, giving them a prescription for PEP and instructions on how to use those and come in for testing immediately after. The guidelines are inclusive of PEP in pocket. I think that they talk about the pros and cons of them, but it is something that I think we haven't really had a great strategy for rolling out PEP in ways that I think reach those who might most benefit. And PEP in Pocket has been used more systematically in places in Canada, and I think that they've had some really good success in time to PEP initiation, acceptability, and feasibility. So I think that this is going to be something that's going to be of growing popularity.
Yeah, this was originally suggested by Gladys Knight in the 1960s.
That was a couple years back. Okay.
That's a
What's old
dad
becomes new
joke.
again.
Only the older people understood.
Yeah. All right. So the last case is a 32-year-old man. This is a case that we saw at one of our local STD clinics. So he goes to a local bathhouse most weekends for sex. He has been prescribed daily FTDF for PrEP 3 times over the past 5 years and agreed to take it, but never actually did, saying, "I'm not a pill taker." He started long-acting CAB 9 months ago to better align with his wishes for PrEP. He comes back in for his CAB injection 24 weeks after his last CAB injection. So he's condomless receptive anal sex with several partners of unknown status 2 days ago. And since he's been on care and now he's there at the clinic, he wants his shot. So what do you do? Do you do nothing and wait for the HIV test results and then decide? Do you give BIC TAF FTC for 28 days? And if he's negative, restart IM CAB? Do you start BIC TAF times 28 days? And if HIV testing is negative, start lenacapavir for PrEP. And if you restart IM CAB today, you have his drugs already in the lab, and you could give it to him. All right, let's see what folks think about this case.
Exactly. It is.
All right, so about 2:30. So about 65% of people want to give PEP with BIC TAF. You've read the guidelines. And then if he's negative, you want to restart lenacapavir. Okay, and then about a third want to give BIC TAF FTC and then restart IM if that's CAB if it's negative. Panelists, what do you think?
I know we were just talking about this, so he's already told you, I agree with C for now, but there's a lot of caveats here. So one, he just told you he's having a hard time. Doesn't like taking pills every day, so we have this issue. But yes, he needs testing and PEP. But there is a concern also with the cabotegravir. Did he develop also integrase inhibitor resistance? And so we don't have the other option, which would be more pills, which would be darunavir or tonavir or Cobicis, I don't know his other comorbidities. So I guess if this is like assuming that's all okay, and I don't have another choice. But the other one is, is lenacapavir, and there's a lot of things, again, assuming we're going to have the same issue, but which I didn't say this before, but the other thing we should be thinking about when we start these long-acting injectable meds is not just assuming that patients know that they can come into the clinic, and at the same time you're having that discussion is thinking about other ways that you can remind people, but going to where they are, doing frequent reminders, community health workers, peer patient navigators, mobile units, et cetera, to just continue to help them overcome these challenges of but that's another thing. But yeah, our options from the choices, I just am a little bit worried about potentially integrase inhibitor resistance.
Mm-hmm. Great.
Yeah.
Other thoughts on this case?
And, I just want to pile on about, he's not great with his visit adherence, and you still do have to come back for lenacapavir. So,
you go to him and you bring it to him.
Yeah,
and you administer it.
If you can, not everybody has those capabilities in their clinic. That's a problem, It'd be great if we all did have, street medicine or mobile clinics or extended hours or weekend hours. Yeah. And, hopefully we'll be moving in that direction. But I know in my space, it's really a lot of work to keep up with when people are supposed to come back, because we do call them, we do remind them, you know, we really, and then if they don't show up, we call them again and we try to figure out how can, you know, do we need to send an Uber for you? Do we, you know, we do things like that. But, you know, it's easy to say 6 months is going to be great for visit adherence, except you still have to get that dose in at the proper time. So.
Yeah.
Yeah, so,
Great.
I just think this is a thorny issue. This is somebody who said that they're not good with pills.
Yeah.
And they have also been on injectables with cabotegravir, and the last dose was 20 weeks ago. So we have, number one, the very likely, the risk of having acquired HIV during that those lapses of adherence are high. They have been on a regimen, a PrEP regimen that contains integrase inhibitors, so the likelihood that they have acquired a virus that is resistant to that is high. So we don't have good options at that point. And just like Sandy said, but I probably would go with C as the best answer.
Great. Okay. All right. Let's see what happened. So this is just a graph of his injections. So I think that, you know, we talk about initiation and then coming in for these visits. And I think, like we see with oral PrEP, we're going to see a lot of people missing injections. And I think we have to come to a consensus with shared decision-making about when is it just that life happens and you miss a shot versus this isn't working for you as an intervention. And so... Oh, that's a big stack of cards. And so so he missed his 24 weeks. So this is a highly doctored, not for the data, but to make it clear, that just shows the PK, and that would by every doses every 2 months. There is a very long tail, and so he is sort of at the point of the tail where he may be above what has been associated with efficacy. So it's late, granted, but it might not be so late that he hasn't had protection for most of that. Whether that existed in the last 48 hours is a question, but as has been commented on the panel, he's already not only said that he's not a pill taker, but shown that he's not a pill taker. And you want to be careful about making sure he doesn't leave the clinic without any prevention. So what happened was, I think, what everyone talked about here. They talked about PEP, given the exposure, that his CAB is not PEP. He might have Levi. His testing was negative. He reluctantly agreed to take PEP and then resumed CAB in 28 days. But what happened is he actually didn't take it and came back in clinic and was diagnosed with HIV. And his CD4 count was 653 at the time. His viral load was 5,000. He had no mutations, and he was suppressed on big TAF FTC. And I think this was a lesson for all of us around making sure that people using this shared decision making, PEP would have been what we recommended. But if he didn't want PEP, then we would have given him the CAB-LA. I think in retrospect, injection. We had the results back, and then would have called them back. Made sure we had a clear plan if that test came back positive, that we could get him started on treatment right away. When we saw resistance, it was often with prolonged exposure after CAB-LA administration. It wasn't like you had resistance a week afterwards, so you do have a little bit more time, I think, from the clinical trials. So this is a great lesson for us, and I'm happy to take any questions, and thank you.
You have a stack.
Not surprising that there are a lot of questions. We'll go to the microphone first.
I don't think it's on.
Yeah, there you
On?
go.
Oh, there.
Perfect. Thank you very much for all of your comments and thoughts. I wanted to just go back to the second case with couples of different statuses. And I find that this is something I counsel a lot about. And I guess wanted to hear from y'all what those conversational points that you're fielding, especially as we're talking about offering up like the RNA testing for that patient who had, and she was non-adherent, but partner was suppressed on gabapentin, and just how we are having those conversations without diminishing U equals U, and what those conversations look like, and what your guys' like personal conversations look like during those kind of opportunities. if that makes sense. I'm sorry if I'm rambling.
Yeah, does anyone want to talk about how they handle that?
I mean, I can offer just some quick thoughts, and I would love to hear yours as well. But I mean, sometimes I'm in a great position where I'm actually caring for both partners. That's not always the case. But even if you know sort of what the other person's care context is, I think it's really important that you're still, treating the person in front of you and like really tailoring it towards their values and preferences. And so sometimes it's hard to tease out, is this from them? Are they getting some external pressure that we just need to like learn a little bit more about? And in terms of sort of U equals U, I think that's an extraordinarily powerful message that this community needs to carry on. And yet people are getting information from other places as well. And so that I think is just sort of like what you have to try to understand. What is it people are hearing? Offer information based on our clinical experience to either counter or affirm that. And then, in the best scenario, people are going to stay suppressed. In the tough scenario that they might have low-level viremia, then I just sort of take the conversation to the next level. And if someone is having virologic failure, then I'm like mobilizing different interventions for everyone involved if I can.
Yeah.
The other consideration is that for the partner of someone who has viral suppression, they're unlikely to get HIV from that partner. They won't get HIV from that partner, but they could get it from another partner. So part of the discussion also is, is this a monogamous relationship? Is there anybody else in the mix? And so I think that's the kind of discussion you have to have, in a sensitive, private way so that the person knows their confidentiality is paramount and, to try to find out what the likelihood is.
I took a similar approach to that, and I used to say, ask patients if they had any guest stars in their relationship. And then a patient reminded me he's not a star, he's just a guest. So then I started asking if there are any guests in the relationship, because then it gives you an insight into like what other things are going around.
Can just be a cameo appearance.
Hi, first of all, I want to say hello to Trip. I'm still working, yes.
Nice to see that.
I have been a nurse since 1979, diploma program. So your job is to figure out how old I am, okay? Secondly, I became a nurse practitioner in 94, but in 79 and 80, we used a lot of drugs that burned the skin and stained the skin. So if you do lenacapavir, I do my own lenacapavir, cabotegravir injections, and my own hormone injections. If you pull a tiny amount of air in the bottom of the syringe after you pull up the medicine, tap it to the top. When you inject, the last thing that goes in is that tiny little drop of air, which will never kill anybody, but it seals the medicine in the skin so it doesn't seep out. Tab is different because you're doing Z-track, but with the Lena, it works like a charm because there's nothing worse than seeing it run down somebody's belly and say, did I give it to them or not? So that's just a little nursing tip.
Great. We love those pearls. Thank you.
I always like hands-on experience. I'll tell my if you're on the.
What do we say about networking? Okay. Resistance testing for lenacapavir, is that commercially available to us now?
I don't believe it's commercially available. Hopefully, as we start to use this more and more, and there's a combination daily regimen that's coming through clinical trials as well with lenacapavir. So we might have it more available, and I think hopefully we'll have the resistance testing available. Now it's available in research labs.
And I don't think there are data, but is any safety data on lenacapavir in pregnancy?
Yeah, so the Purpose 2 trial was actually a well-designed trial that actually allowed individuals who became pregnant to sign an additional consent to continue the use of lenacapavir for HIV prevention throughout pregnancy. And we didn't see any adverse pregnancy outcomes above what was in the background. And so I don't know if any others on the panel want to comment on that, but it's been really helpful to have those data.
There's been a few real-world case series published where women were on long-acting injectable, and some people also had len as part of their regimen, so treatment.
Yeah.
This is a big switch in the way research is being done, where pregnant women are allowed to continue, and that was true in Purpose 1. So
Yeah.
they did compile the pregnancy information. There were a lot of pregnancies, and they did not see any adverse birth outcomes, although it's still a small denominator to be able to say it's safe.
Yeah.
And they did have to administer in a different location too, because during the pregnancy.
Because of pregnancy, yeah.
But I think what Tripp was saying, and I wanted to point out, I thought that was amazing that they included pregnant persons and it was because they listened when a woman stood up and said, I don't want to get HIV, and I don't want my baby to get HIV, and they listened, and they included the individuals Gilead did in that trial. So we need to do more of that.
And it has changed. The phase 3 trials that are going through now are actually using that same strategy, and I think it really is, including individuals in research and not preventing them and trying to protect them from research.
Michael?
Thank you. I had a question about the off-label use of TAF in women and how you may get that approved. I don't prescribe PrEP in my clinic. I only take care of HIV patients, but I've heard that sometimes the PrEP has not been covered, and especially for, Descovy versus Truvada. I'm just wondering if you could elucidate a little bit more and help me understand how you would perhaps pursue that.
We've had trouble. We've had the TAF FTC denied for people for whom it is FDA labeled, and I think that that's a lot of insurance companies that have put restrictions on it because generic Truvada is just so, or generic TDF FTC is so inexpensive in comparison. So I think in our publicly insured individuals, we have been able to get TAF FTC without any difficulty. It's more the private insurance companies that we've had struggles with to get it covered.
All right. Thanks.
But no one has referenced the data actually in their denials.
Yeah.
It's all about the money.
Okay.
Yeah.
Just because it's more expensive.
Go this microphone. Oh, go that microphone. Go ahead.
Hi. Hi, Dr. Glick. I'm from New York, too.
Yay.
As the director of the HIV program, I do take care of HIV patients. However, I'm also the director of the TB program. So I'm wondering, I had a few cases where I had to use drug-resistant TB cases. So I'm wondering the use, you said, of lenacapavir with TB drugs. Any thoughts on rifampin, you said, was a problem? Or could that be used as well as the BPL regimen?
Does anyone want to take that?
So it's all the RIFA drugs,
Yes.
I think, and bedaquiline as well, right?
So what, she wants to know what.
I think it's like any other potent interaction with CYP3A4 that rifampin is, you can't use with lenacapavir. I'd have to talk with a pharmacist, but mostly I would carefully work through that. But generally speaking, I would avoid lenacapavir in general with TB therapy until I've worked out a specific regimen.
It is tricky. Len's an inhibitor, and then you got rifampin on top of that, which is an inducer. So, yeah, talk to a pharmacist and.
Yeah, phone the pharmacist.
This one's a tough.
Don't ask us.
So the problem is,
You can go to Dwayne Reed where you live, or
we
the
have
rest
a
of
lot
us.
of, I had few cases, 2-3 cases, I guess, in the last few years for the BPL regimen, and they were all rifampin-resistant cases. So I had to use the.
I mean, my approach is what you all do. Sit down with the Liverpool interaction site and put each of the drugs in with lenacapavir and see if you can get some input there.
That is a great resource if you haven't used it. It's fabulous. Yeah. Got time for one last question.
Yes, thank you. So going back to the FTAF with women and receptive vaginal intercourse, can you just provide some clarity, counseling clarity? Because I just did this the other day, and it was my N of 1. When they are protected with front hole sex, because I know the Brits have a little bit of a different kind of take on this, and I've heard differing things from the Gilead scientist, and so I just said 3 weeks based on what My old resident Rafi taught me. But anyway, I would love to hear your thoughts on that.
Yeah, I think that this idea of time to protection has been challenging because a lot of it is not, like, we didn't have any clinical outcomes associated with the time from initiation to the time in which we didn't see HIV acquisition. And in the PrEP trials, it was often unrecognized HIV acquisition in the beginning before they initiated, that not like we saw these infections occurring within 2 or 3 weeks after they enrolled into the studies. So we do sort of reference those guidelines of time to protection. We sort of give the caveat that we don't have clinical outcome data to say that this is 3 weeks, like this isn't a firm, this is all based on PK data. And that, we initiate after an exposure for PEP with these drugs. I know we now use 3 drugs, but it wasn't because the 2 drugs were failing all the time. And so it is a nuanced conversation. And in the clinical trials, there was not counseling to wait to start having sex before the oral PrEP trials, for example. So, people were having exposures, acquiring STIs. And so it does become a nuanced conversation. You don't want someone to have a false sense of security, but we also don't want to undermine the true potential efficacy of these drugs for HIV prevention. So I think using those is probably the most conservative, but if someone has sex, within that time period, I don't initiate PEP, for example. If someone has sex a week after I initiate them on PrEP and they've been taking it, that's not a PEP indication for me. I'd love to hear if others feel differently, but we sometimes make it so hard for people, and then we wonder why they don't stay on it.
Thank you.
So it's maybe good if your football team's in the red zone, but it's not good if your timer is, so we have to sort of cut down here. And so thank you. I know there's some more questions, and there's also a lot that we didn't get to on the cards, but Dr. Scott's available right after this, but also in his breakout session.